Welcome viewers, welcome friends, welcome my dear colleagues, my dearest students, residents and fellows on MuniMeterHealth, your source of learning cardiology and human heart. This is Dr. Jaitly. Welcome again on MuniMeterHealth. If you're experiencing an emergency, please dial 911 and get to the nearest hospital, consult a doctor. This is purely an educational channel, as we are trying to improve the medical education and the patient education in order to improve the health literacy and thereby improve the clinical outcomes. So please note that if you're experiencing an emergency, please consult a doctor right away. It's purely an educational channel. Without any further ado, let's delve into the subject matter right away. What are the causes, the cardiac causes of syncope? Of course, we'll discuss the non-cardiac causes very briefly, of course, because that's beyond the scope of this short video. But the whole idea is wanting to concentrate what are the cardiac causes of syncope. Well, what is syncope? Syncope is an abrupt loss of consciousness as a result of global cerebral hypoperfusion, accompanied by a total postural tone loss and followed by full spontaneous recovery. So in other words, you have to have three components. One, of course, you have to have a decreased cerebral perfusion, if you will. I'll just write it down for you guys. Two, you have to have a loss of postural tone. So remember, the postural tone is coming from your predominantly from your calves, and that's where the peripheral resistance is. So loss of postural tone will result into that. And thirdly, a spontaneous full recovery. So there is a full recovery as a result. So that has to be present, a full recovery, spontaneous, that occurs rather quickly. So these are the three components of syncope. Now, cardiac causes, I've tried to summarize them into these 4 or 5 outlines here. A pump failure, let's discuss that first. Well, there we consider heart failure. Like if you have an ejection fraction which is markedly low, we're talking about ejection fraction less than 35%. Now, to that, I refer you to my heart failure slides and videos, but the point I'm making is ejection fraction, of course, for the sake of the students, I should say that it is a measure, it's a marker of heart failure. Normal ejection fraction is 55% and over. Heart failure, ejection fraction, when we are talking about 35%, we're talking about severe heart failure. Sometimes I've seen in my long career of practice, I've seen ejection fractions in teens, and many times, or it's not uncommon to see them even in single digits. So you have to have a pump failure so that the blood is not actually being pumped into the aorta as much, and as a result there is a cerebral hypoperfusion, implying that the brain suffers a full hypotension or a low perfusion state as a result that the person passes out. It has to be bilateral cerebral dysfunction, perfusion, remember that. It's not just one-sided. Now, so that's heart failure. The second thing is you should consider massive MI. So whenever there is a massive MI or a heart attack that has occurred or previously known heart attacks, there could be a cause. A left ventricular obstruction is very, very important. I'm going to say left ventricular obstruction. So here the aortic stenosis. Do not forget the IHSS, which is a very, very important cause of passing out spells, specifically in exertional syncope, and we'll get to that in a second. So AS and IHSS, and many times a very severe tight, we call it, tight MS. Mitral stenosis, aortic stenosis, idiopathic hypertrophic subaortic stenosis, and severe MS. These are the commonest causes of left ventricular outflow obstruction, again implying that the cardiac output is markedly decreased in both the states, in both these categories. Cardiac arrhythmias. Yes, the cardiac arrhythmias are very, very importantly known. Now here you have to ask several questions. Again, I cannot underemphasize and I cannot, I must say that it's an understatement that you have to do the history and physical very, very thoroughly in order to ascertain if this is a cardiac cause of syncope. Remember, you have to ask Is there a syncope that occurred during the change of posture? That the patient was supine? Was it a patient who was exertionally performing, and that's when he or she passed out? So there was an exertion involved. Were there palpitations present at the time? Very, very important. And of course, you have to find out if there's any family history. If there is a family history of sudden cardiac death, previous histories of syncopes in the families, or if there's been sudden cardiac death episodes, then that is a very, very, cardiac stigmatic cause where you have to explore it very, very thoroughly, because these patients may pass out, may present with sudden cardiac death episodes also. Now, it's important that on the EKG, you might find certain stigmata. Now, a non-sustained VT, we call it, NSVT, if that is present during the time and the Holter monitoring was going on, for instance, or there was a telemetry monitoring going on, or the patient actually, when the EMS arrived, they ran the first EKG strip, and it turns out that showed non-sustained ventricular tachycardia. Patients who have bundle branches, remember that bundle branches blocks cannot be totally dismissed. Now, a lot of patients have abnormal EKGs with bundle branches. Doesn't mean that's a connotation of a future syncope. But somebody who passes out has syncope and a bundle branch present. You have to be very careful what you're looking at. One, you have to see if the QRS is prolonged, more than 0.12 seconds or 120 milliseconds, whichever way you want to look at it. So QRS more than 0.12 implies that is a significant intraventricular conduction delay that is present. We write it down as IVCD. The other thing you have to see is if there is a short QT or if there is a long QT. Now, long QT sometimes can be related to the drugs as well. So remember that. We'll go over that in certain categories of drugs. But the short QT and long QT both will have to be assessed. And these QT should be adjusted to so it's a corrected QT based on the RR intervals. So remember that RR interval will have to be looked at in these on the EKG. So it's very, very important. Now, the other causes, for instance, is there a pre-excitation syndrome present, like a WPW? Now, Wolff-Parkinson-White syndrome implies that there's a short PR. That's a very easy thing to really see on the EKG. A prolonged QRS, more than 0.12. PR is short, less than 0.12. So this is 0.12 or less. QRS is more than 0.12. And there's a delta wave. We call it a delta wave. Which is like a little slurring of the upstroke of the QRS present. So that's WPW. You may have a LGL syndrome where there is only a short PR. So that's a short PR with other criteria not meeting. So you could have all these pre-excitation syndromes. The other thing that you have to also worry about is there any right bundle with a Brugada pattern? So let's write Brugada here. What is a Brugada? Where you have a right bundle, I'm writing it down, right bundle branch, and then you have ST elevations in V1 to V3. So V1 to V3 right precordial leads will have ST elevations in a right bundle branch setting. Now these patients normally they are from, commonly they have been seen in Mediterranean descent, Italian descent, and of course in some Asian populations also now increasingly we are seeing Brugada being present. And last but not the least, you should also look for epsilon waves. Epsilon waves can be present specifically when you have negative T wave inversions or negative T wave patterns in the precordial leads, V1 to V6, but predominantly in V1 to V4, right precordial leads, in a setting where somebody has ARVD, which is arrhythmogenic right ventricular dysplasia. Now that's a congenital condition, remember, where the right ventricle is extremely weak. It is lacking. Here I'm drawing it in the structure here. Right ventricle is weak. As a result, there is no cardiac output occurring into the pulmonary circulation, and sometimes even these are very arrhythmogenic substrate for non-sustained VTs, or sometimes even VTAC and VFs. So sudden cardiac deaths can occur in these patients who have ARVD. Now this is a very common cause also of an exertional syncope, commonly seen in younger individuals, specifically if they are basketball players or football players or soccer players. So these patients can actually collapse in the field or on the court, and as a result when somebody does an echo, you can actually see lack of muscle in the right ventricular free wall, and again, this is confirmed by a cardiac MRI. Now, that brings us to very important places. What are the diagnostic tests that one would do? Obviously, you're going to do an ECG, because a lot of the things that we just enumerated here will be excluded or confirmed on EKG patterns, correct? Next, you would do an echo. Echo, if you do, it's a non-invasive test, and you could identify the heart failure, the ejection fraction. You could see there was a massive MI that the patient has had or is having one, or any other causes of left ventricular outflow obstructions like aortic stenosis, IHSS, and severe MS will all be identifiable on an echo pattern. Okay, and including an ARVD can also be seen on an echo. The third thing that you possibly can do is the stress test. Now, you don't want to stress this patient during or immediately after the syncope, etc. You really want to have these patients sort of stabilize first, make sure that there are other non-invasive tests that have been done, and then do a stress test to rule out any possibility of severe ischemia, severe aortic stenosis, specifically if it is exertion related, or sometimes exertion related arrhythmias. Cardiac arrhythmias can also occur, and a stress test could be recommended. A cardiac MR, I would say, a cardiac MR is recommended only when you're suspecting, say, a Brugada syndrome, or you're suspecting ARVD, for instance, or you're suspecting some form of an IHSS or a cardiomyopathy, like an amyloidosis, etc., as a result of syncope. So as a result, you can order these various testings, but again, not all testings are required in all patients of syncope. Remember that. Now, medications and drugs. Remember I talked to you about very briefly about the long QT. Now, long QT can occur because of certain medications. Now, specifically so the beta blockers, remember? They can prolong the QT. Calcium blockers notoriously also do that. And there are certain type 1A groups of drugs, specifically procainamide, quinidine, and these are antiarrhythmic drugs. Patients could be on antiarrhythmic drugs, and they can cause prolonged QT, and as a result, these patients can result into torsade. We call it torsade de pointe. It's a French name, torsade de pointe. Point test. So this is a torsade that can occur where the EKG is actually more like a spindle. It goes around. If this was the baseline of the EKG, it will go more like as if the QRS complexes are just sort of doing on a spindle form. So that's a torsade. That is, I've seen cases where type 1A drugs have had these problems in a telemetry setting where we admit these patients for syncope. I've seen beta blockers, which is very commonly employed, as you know. Now, in medications and drugs, also remember that you have to worry about the diuretics. You have to worry about simple drugs where patients could be on any cardiac drug, including ACE inhibitors, ARB, or angiotensin receptor blockade drugs. All of these, most of the cardiac drugs can cause syncope, specifically so if these patients are orthostatically hypotensive. In other words, that their volume depleted. If their volume goes down, any antihypertensive, any cardiac med can result into an orthostatic hypotension. So therefore, I've included these causes here: vasovagal, orthostatic, and neurogenic, in the bottom of my list, primarily to ascertain that, again, these can impact, if specifically so, if these patients, in other words, there are hypertensive patients walking around, on antihypertensive drugs, but they are normotensive right now. Now, what happens is, say they step into a sauna room or they step into a steam room where there's immediate change in temperature as a result of peripheral vasodilatation occurs, and specifically so if they're volume depleted, if they are dehydrated, that'll result into an orthostatic syncope or dizziness or lightheadedness. They can fall. And there have been instances, again, I'm a regular user of a steam room or a sauna. Myself, I always carry a bottle bottle of water regardless, even though I don't take any medication. The point I'm making is I think it's a highly recommended. I always recommend it to all my colleagues and my friends. I said, look, you gotta take your water with you inside the sauna room, because regardless whether you are considering yourself normal volemic, the chances are you will become hypovolemic by the time you exit the sauna room. Or likewise, if you are stepping out into, say, you're doing an exertion on a mountain in a hot summer day, or you're going out hiking in a desert or someplace. So all these things can really, if you do not have the water and you have these cardiac meds on board, as a result, orthostatic hypotension can occur and patients can have syncope. Remember, the incidence of syncope across the whole planet, I always ask that question, is almost 45 to 50%. So 45 to 50% of the population on this lovely planet will pass out one time in their lives. So I got some good news here. So syncope is very, very common, but cardiac causes of syncope is highly treatable. It should be identified as early as possible because it has the highest amount of morbidity and mortality. Remember that? So therefore, if anything that is ignored here can result into serious problems later on. Therefore, ECG, echo, Holter. Remember, the full 24-hour Holter monitoring or even extended monitoring should be done in these patients in order to ascertain if there was a non-sustained ventricular tachycardia bundle branch. Do not forget the sinus bradycardia, sometimes the sinus arrests, and even the sinus pauses that can occur. And those will be identifiable on the Holter monitoring, because many times you could see that these patients, when they're admitted for extended monitoring, etc., these patients will demonstrate inappropriate sinus bradycardia or inappropriate sinus, sinoatrial blocks, etc. And those could be, or sometimes a morbid still you could see, or any AV blockading, AV blocks or high-grade AV blocks or complete heart blocks. So these are the other causes of bradycardia, and those cardiac arrhythmias you should really enumerate. So having ascertained that, now remember, IHSS will show up here where there's an outflow obstruction, and I'm just showing the septum being very, very thick in these settings. It's not only thick, but it's also asynergic or dyssynergic, where the myofibrils, and one can identify that on an echo, where there is a left ventricular outflow obstruction. As a result, the blood flow going to the aortic, passing through the aorta is lessened. And as a result, the cardiac output obviously is profoundly low. So one has to really ascertain these quickly by getting an EKG, an echo, a stress if indicated, and a CMR if indicated. But a Holter, and between the EKG, echo, and Holter, you should be able to identify most of these conditions as I've enumerated as a cause of cardiac causes of syncope. Okay, again, this was a very, very short, quick run-up for causes of syncope. I'm sure you enjoyed it, and please do not forget to press the like button if you like it, and of course share it with your friends, subscribe my friends, and of course keep watching on MuniMeterHealth. I'll see you again, guys. This is Dr. Jaitly from New York, your cardiologist. Thank you, and have a lovely day. Bye.